So we're just here to take a look at lateral recumbent when working in front of the patient. So given the fact that previously we've discussed the concept of patient positioning, that the table makes stable and less stable means I need to make the patient more stable, such that in lateral recumbent, the most efficient place to work is from behind the patient so that you can bring them towards you. Also, you can make sure that their legs aren't, when they start to bend the knees or flex the knees and flex the hips, that they aren't likely to start falling off the front edge. Now, there are times when it's useful to work in front of the patient, and the same concepts still apply, but the way to actually get that done will start to change. So we still look at the fact that less stable means I need to make the patient more stable. So there is a space that we've talked about from wherever the edge of the table is. That's as close as at least my legs can get. I cannot get closer with my legs. My body can get closer so I can lean in. Now, one of the challenges with this is if you do this a lot, so your thighs will contact the table and you lean forwards to make contact with the patient, as we'll do in a moment, it really starts to put a lot of stretch and stress and strain on the practitioner's hamstrings. So if you're living your everyday life and you're treating in front of the patient a lot when you're in lateral, or when the patient's in lateral rather, and all of a sudden your legs start to hurt, it's probably because you are habitually doing that. So it's something to consider for the longevity of the practitioner. So what we're going to do, just going to slide forwards a little bit. Okay, all right. Now you see how when the patient slides forward, I control him, right? So I make sure that he can't go farther on his shoulders than I want him to. So as he comes too close, I'll push back. If he's too far away from where I want him to be for whatever reason, in the hips, I can start to guide him. I use haptic feedback, so I use touch to make sure that he knows where he's supposed to be, or whomsoever's on the table has an idea. I don't let them guess. I don't let them shimmy a little bit forward on their own and a little bit back. I'm like a little bit forward, a little bit back. It's not hanging a picture. We're not trying to get the corners to line up. What you need to do, because this is somebody moving and they will move unevenly, is you use haptic feedback or the sense of touch to help direct them, right? So if you put resistance on something, they're not going to go that far. If you let something be easy, they'll go farther. Okay, so we'll just have you slide your hips a little further forwards. There you go. And again, this concept of contact is control. So I leaned in until my abdomen touched his thigh. I wrapped around to make sure that he knows that he's in a frame. So essentially I framed him to create the space. Now, what we're going to look at here, we've talked about the fact that in lateral, rotation of the vertebral column is quite easy to do. But what we're essentially going to explore very briefly is the position or the movement that a lot of people will call a side roll. Many people will see this in varying forms of manual therapy. Most commonly, what you will see is people will use this to get cavitation or a crack out of somewhere in the back. Now, although some people will claim they can be very specific with it, I would suggest that they can't. If you pick somebody's leg up, right, and say you do a straight leg raise, and something cracks, it could be their back, their knee, their ankle, or their hip, and you wouldn't know. You think you know because you felt it down here, so you will think it's the ankle, but it could have been anywhere along that lever. So if, as I twist somebody, something cracks, it cracked, it made noise, it doesn't mean I know where it is. Because also the feeling, the sensation of it, so if I'm touching here and something pops, I'll think it's here, but it could have been up here. So it's just something for you to understand. So the specificity of it, although some people will claim that they can be quite specific, I would suggest they probably aren't as specific as they believe they are. It's not to say it's impossible, it's to say it's less likely than many people believe. But what we're going to talk about is the ability to rotate the patient and the ability to move, right? So we have multiple points of leverage at play. As far as rotation is concerned, for the vertebral column generally, or the lumbar column specifically, although it doesn't rotate much, there is rotatory movement available in a gross fashion. I can move the pelvis, right? I can move the pelvis in relation to the thorax, right? So if I blocked in the thoracic region, I can move the pelvis, generally speaking. Or I can move the thorax in relation to the lumbar column if I block in the middle, or I can move the upper girdle or the thorax in relation to the pelvis, or I can move the pelvis in relation to a stable thorax, right? So I can take the shoulder away from the pelvis, or I can take the pelvis away from the shoulder. So if I wanted to rotate, for whatever reason, this region towards me, then what I would do at that point is the leg would end up coming off the table. If I wanted to rotate, for whatever reason, that way or away from me, then I would do it from the top. Now, the ways in which we begin to gain control over the patient effectively is right here. So we secure the upper portion, we secure the thorax. Now as we do this, you won't be able to see it. My elbow, right, at the moment it's loose. This depends on the fit between the practitioner and the patient, right? If you have your forearm broadly going over the ribs on somewhat of an oblique angle, and as you wrap around it, if you stay wrapped relatively loose through here, if you lean in or you grip, you'll start to squish the ribs. But if you stay relatively loose, as you begin to lean in, you're going to create elbow flexion on your own of your up table arm. As you do that, your elbow will splay out just a little bit and you'll be nice and tight, right? So you'll be in there. Now I would say you don't aim for the patient's arm. For control, especially because the thing that's going to become the most difficult to control is going to be the leg and the pelvis, because the leg is going to act as counterweight in a moment. The lower portion is much more important, and the way that I'm going to control that is with my down table thigh. Although it's not visible here, we're going to talk about it. Okay, so what I'm going to have you do is I'm going to control him. Okay, I'm going to hold onto his leg, straighten your bottom leg. Now him straightening his bottom leg means now I have essentially the side of his body that's on the table can now roll relatively free. Now you see how I'm holding his leg. I can just start to roll him around. The way that I'll speak about this to my patients is I'll say, if your legs are straight, you turn into a log and it's easy to roll. If his knee's bent, it abates the ability to roll him. So I have him straighten that bottom leg. Now, you see how that leg comes into me. I put that thigh, his thigh against my down table thigh. And this is where I'm going to lean in. So there's more of me. So now it's just not my down table thigh, it's also my abdomen. There's more of me in contact with him. Now, let this hang. Now as it hangs, right, it may not go very far because I blocked it, but nothing moved. I was able to control him. So now, you'll see one of the tendencies here, for some practitioners, not all, is to wrap around. So now, as I wrap around, I have more contact. So I have my abdomen, my thigh, my down table thigh in contact with his thigh and with his leg. I have lots of contact here. So now he's essentially framed. Okay? From this position, should I want to, I can move the shoulder away from the pelvis, or if I want to move the pelvis away from the shoulder, what I have to do essentially is stand up. Now you'll see this. As I stand up, I can roll him. So if you pay attention here, now the pelvis is essentially moving away from the shoulder. Right? So the pelvis is moving forwards, the shoulder essentially stays still. And at this point, we've started to create rotation. So we can create rotation from the top, we can create rotation from the bottom. Now, these hands, as they wrap around, if I'm thinking about the lumbar column, now this contact, this forearm, down table forearm, allows me, in concert with my thigh, to begin to augment where his leg is in relation to his lumbar region. So I can begin to create relative flexion and relative extension. Now it doesn't work easy on everybody. On some people it works better than others just because of their movement capacity. But because I've got them trapped, and you see contact, contact, right? Now I can start to create all those motions that I want. So what we're really looking for is the ability to utilize this to put motion where we desire, right? And that comes through the concepts of patient positioning. So less stable means I need to make the patient more stable, so I bring him towards me. Contact is control, and control is safety. That means I get lots of contact with him. And then we're thinking about relational motion. So relational motion, I could either move his top shoulder backwards, or I can move his pelvis forwards in relation to one another. And then I can move his leg in relation to his trunk, right? So that I can start to create motion. So there's a lot of leverage at play. And the way to control all of that really comes down simply to contact and patient positioning and relational motion. Once I have those things understood, I can start to wield them. They become useful to me. Now there's many other things that you can do from this position or within these movements. We don't have to go through them exhaustively, but if you have those keys down, the concepts of patient positioning, again, less stable means I need to make the patient more stable, bring them to me to get more contact, because contact is control and control is safety. And then I can create whatever relational motion I want when I have those set.